Hello guys. So now coming to the last discussion about our series, that is gynecology. Okay. So beginning the gynecology, we'll learn about some of the important anatomies of gynecology and uterus, and then we'll learn about physiology, and then we'll dive into the gynecological disorders. Okay. So the first thing you should be aware of is the level of supports of uterus. Okay, so this is called De Lancey's levels of support. There is three levels of support: level 1, level 2, and level 3. So level 1 support is by uterosacral ligament, transverse cervical ligament, and pubocervical ligament. Okay, so this will form the first level of the support. Then the second level will be the levatorinae fascia and the muscles and the fascia around it. Okay, so then the level 3 of support will be the perineal body and the muscles that form the perineal body, the membrane, and the superficial and deep perineal muscles. Okay, these are the levels of support. Okay, so then coming to the physiology with regards to gynecology. So basically we'll see the ovulation summary. Okay, so the reason why we are learning about the ovulation summary is there comes of pathology called PCOS. This summary is very important. Okay, so what happens is, so hypothalamus basically it releases the gonadotropin releasing hormone and stimulates pituitary gland. From anterior pituitary, LH and FSH will be released. Okay, so this will come to the ovary and stimulate the follicular maturation will happen. This is by FSH. The definite function of FSH is follicular maturation, whereas LH will act on the theca stimulation. Okay, so theca stimulation is the main action. I'll come back to the ovulation thing. Okay, so this is the two main action of LH and FSH. Okay, so here so basically what is happening is, so how the maturation and the theca cell stimulation is happening is, so what happens is LH will cause theca cell to generate androgen. Okay, androgens basically testosterone. So this testosterone has to be converted to estrogen. Theca cells by itself cannot convert testosterone into estrogen. So that is why there is something called granulosa cell within the follicles. Okay, so suppose this is the follicle, there is theca cell on the outer surface and there is something called granulosa cell on the inner surface. Okay, so this testosterone that was formed in the theca cell will get transferred into the granulosa cell. So this is where FSH will act. Okay, so follicle stimulating will hormone will act and it will convert it into estrogen. Okay, so this is called the maturation of the follicle. Okay, that is the FSH action and will be converted into estrogen. So now as the day goes on, so estrogen is started increasing. So this estrogen will cause increase in LH surge. Okay, so suddenly what it will do is, so estrogen basically will cause the increase in LH surge on the 14th day. Okay, so on 14th day LH surge will happen. This will lead to ovulation. Okay, so that the ovum that was inside the follicle will get released because of this LH surge. Okay, so the oocyte will come out. Okay, and the meiosis 1 will be completed. I told you right at the beginning of our discussion, the two stages of arrest that happens in with respect to oogenesis is the first one in the meiosis 1. So the basically it will be in the prophase 1 that the oocyte is arrested, and in the metaphase 2 also it will be arrested as secondary oocyte. So now basically after ovulation the meiosis 1 will be complete and the oocyte will go into the second meiosis. So here it will be arrested in the metaphase 2. Okay, so until the fertilization happens, so it will be in the metaphase 2. So now what happens is, so suppose so now the ovum is released and the rest of the follicle is there, right? So the rest of the follicle apart from the ovum that was released is known as corpus luteum. Okay, so this corpus luteum is what helps in progesterone release. I told you right, till almost 8 to 10 weeks, so this progesterone will be released by corpus luteum. Then after that the placenta will take over this particular action and the corpus luteum will be degraded. So if fertilization happens, so this is the thing that is happening. Okay, so the secondary oocyte will become ovum. So once the sperm fertilizes the oocyte, so metaphase 2 will further proceed and all the metaphase the meiosis 2 will be completed and the ovum formation will be formed, and then the ovum will fuse with the sperm and form the embryo. Okay, so this is the entire process of oogenesis and the fertilization that is happening. So you should know the entire summary, and that too this part of LH, FSH, and how the estrogen and testosterone. I'll come back to that again in when I'm explaining about PCOD pathogenesis. Okay, so this is the thing. So while this is the thing that is happening in the ovary, so let us see what is happening in the uterus during this particular stage. So there are stages, okay, that is follicular phase, okay, then the ovulatory phase, then the luteal phase, that is happening in the uterus. Okay, so whatever we studied above is what is happening in the ovary. So now we are seeing what is happening in the uterus. Okay, so follicular phase, ovulatory phase, and luteal phase. See, during follicular phase, it means that it is the first 7 days of the cycle. Okay, so in a month, if there is 30 to 28 days, so what happens is the first 7 days, the follicular phase, first 7 days, the follicular phase is happening. Okay, so first 7 days, follicular phase is happening. Here, all this FSH is raised. Okay, so LH, FSH, all this function is happening in the uterus. Okay, so there is no change with respect to uterus that is happening. Then the ovulation will happen, that is because of LH surge on the 14th day. I told you, right, ovulation will happen. Then on the luteal phase, okay, so basically corpus luteum is what is maintaining it, right? It is the progesterone that is getting released. Okay, so this is the progesterone that is getting released. This happens around 14 to 28 days. Okay, so this is happening on the 14th to 28th days. Once there is no fertilization that is happening, so what happens is the progesterone withdrawal will happen, and again the during progesterone withdrawal, this bleeding will happen. So this is what calls the menstruation. Okay, so then again the cycle repeats every month till menopause. This cycle repeats. Okay, so during this cycle, so let us see in each phase how the uterine cycle is. So during the follicular phase is where the menstruation happens. Okay, so menstruation is happening because of the progesterone withdrawal. Okay, then there is a proliferative stage where the estrogen is acting. Okay, so estrogen is acting, and there is proliferation of the endometrium that is happening. This is basically preparing the endometrium for the embryo to get attached. Okay, so then there is secretory phase where the progesterone will act and cause the pregnancy to continue. So this is the thing that is happening in the uterine cycle. So if there is no embryo, so then the corpus luteum will also fail because there is no formation of the placenta that is happening. So progesterone will be reduced. So when the progesterone is reduced, so the menses will happen. So this is how the menstruation phase and the entire ovulation will be happening. Okay, so now that we know all the physiology and anatomy, so now let us dive into the gynecological disorders. Okay, so first thing is the abnormality in uterine itself. Okay, so uterine abnormalities, this happens because of Mullerian anomalies. So Mullerian anomalies meaning, we discussed, right, in the embryology of the female the reproductive system. So basically what is happening is Mullerian duct is what is generating the or forming the all the internal genitals or internal reproductive system of the female, right? If there is a anomaly with respect to Mullerian duct, these abnormalities will occur. So one thing is uterine diadelphi, bicornuate uterus, septate uterus. These three are very, very important. Okay, so with respect to, they'll give a USG, so they'll give a HSG, and we will have to find out what is happening. Okay, so please remember, I'll give you a tip with respect to how we can identify it. So if there is 2 cervix and 2 uterine heads, it is going to be uterine diadelphi. Okay, so there is, okay, one head, the 2 head is there, and cervix also will be 2 cervixes are there, so it is going to be uterine diadelphi. Okay, then coming to bicornuate, so basically there is 2 heads but there is no 2 cervix. Okay, so this is bicornuate. Okay, this is how septate also looks like. So there will be 2 heads. Okay, and there is only single cervix. Okay, but the thing is, with respect to bicornuate and septate, so the difference is with the fundus. Okay, so the fundus will be normal with respect to septate uterus. It is only a single septate that is inside the uterus, but in bicornuate, even the fundus will be having will be depressed. Okay, so this just by hysterosalpingogram we can't diagnose. So bicornuate and septate uterus we can't just diagnose just by looking into the HSG. Okay, we'll have to do a laparoscopy and then only decide. So if it is bicornuate or septate uterine anomaly that is there. Okay, so that is why HCG and laparoscopy both are very important. Okay, so then also 3D TVUS can be done. Okay, so this is the thing with respect to uterine anomalies. Okay, now coming to pubertal anomalies. So basically, precocious puberty and delayed puberty are the two things that should be that are the anomalies with respect to puberty. So precocious puberty, so is basically failure of appearance of secondary sexual characters. Within 8 years in males and 9 years in females. Okay, so this is precocious puberty. So sorry. Okay, so please forget that. So precocious puberty is basically appearance of secondary sexual characters very early, like 8 years, within 8 years in male and in 9 years only in female. So this is what is happening is a very pre-puberty that is happening. Okay, so there are two causes that have that might have caused precocious puberty. That is, one is central cause, the peripheral cause. Central will be increased GnRH, early increase in GnRH, which should have caused this, or else if there is a external sex hormone production that is happening. Okay, so if increased sex hormone production, that is basically the androgens that is happening. So this is the peripheral cause that might have caused precocious puberty. Okay, so this is one pubertal anomaly. Then the other one is if there is delayed puberty, meaning absence of secondary sexual characters by 13 years of age, or no menarche by 15 years of age, is known as delayed puberty. Okay, so please remember these 2 years. The 13 years is the secondary sexual characters, whereas menarche is by 15 years of age. There are two types of delayed puberty: hypogonadotropic and hypergonadotropic delayed puberty. Hypogonadotropic meaning there is reduced GnRH, whereas hypergonadotropic is basically various causes. Okay, so other various causes will be there. Okay, so we'll see one by one. So now moving on to other disorder with the menstruation, that is menopause. Okay, this is not a disorder, this is a physiological thing that is happening in every female. Okay, so what happens is, so how we tell that it is a menopause that is happening is amenorrhea for more than 12 months at around 50 years of age. Okay, so in old women is okay, or we'll take it as around 50 years, 45 to 50 years of age is when this amenorrhea for more than 12 months, we can tell that as menopause. Okay, so this is due to reduction in production of estrogen that is happening. Okay, after all the follicles have been all the follicles are utilized and there is no follicle in the ovary. So ovary was what producing the estrogen, right? From, I told you, right, FSH, LH. So estrogen was being converted from the testosterone. So there is no follicle, meaning there is no estrogen. So follicles have declined in the ovary. So that is why there is no production of estrogen. So which will stop the menstruation also. Okay, so then menstrual abnormalities for 4 to 5 years will be there before menopause, and there will be increased FSH with respect to menopause. Okay, so this is basically because there is no negative feedback that is coming from the menstruation that is happening. So there is no progesterone basically. So progesterone was what causing the negative feedback for GnRH. So there is no GnRH negative feedback. That is why there will be increased FSH in the early years. Okay, so this is the thing. So the basic clinical feature, we all would have seen this particular clinical feature, that is HAVOX. So remember it as HAVOX: hot flushes, atrophy of vagina, osteoporosis, CVD, or sleep disturbances will be there. Okay, most of the cases that come to our hospitals with postmenopausal symptoms is sleep disturbance and the hot flushes. Okay, so these are the things. So then moving on to the disorders of menstruation. So let us now discuss about the amenorrhea. Okay, so amenorrhea meaning there is no bleeding that is happening. So there are two types. One is primary and the secondary amenorrhea that can be happening. Okay, so primary meaning there is no menstruation at all that has happened. Okay, at the age of 15. This is the meaning is, so basically we are talking about delayed puberty. That is what I was about to tell. So then the secondary is basically the menstruation has happened, but there is sudden disruption in the menses in a previously normal menses that was happening. So for example, a 35-year-old woman, she's having a normal menses till date, but now since a few months she's having this amenorrhea symptoms. Okay, so let us see each of the causes and all. So first one was primary, meaning delayed puberty basically. Okay, so how do we diagnose a case of amenorrhea? Okay, so first thing is, what we'll do is, amenorrhea means, so basically there might be a pregnancy that is happening. Okay, so that is why we'll rule out the pregnancy first. So that is why we'll give a UPT test. Okay, so you will give a card UPT test, and we'll check for your pregnancy. Okay, and also we'll check for cyclical pains that is happening. Okay, if cyclical pains is there, so now after UPT, so what we are going to do, we are going to go for examination for the patient. So we'll ask for the symptoms. So we'll ask if there is any cyclical pain and all. If cyclical pain is there, so we'll have to rule out imperforate hymen and the transverse vaginal septum, which would have been not allowing the menstruation blood to pass out. Okay, so imperforate hymen and this vaginal septum would be not allowing. So menstruation is happening, but this septum is not allowing the blood to flow out. Okay, so this is the first thing we should rule out with respect to amenorrhea. Then what we'll do pervaginal examination and ultrasound. Okay, so this is to decide whether the uterus is present or not. So now the basically, so the amenorrhea is there, bleeding is not happening. So now we are trying to elicit whether there is a uterus or not. Okay, so suppose if there is uterus present, what we'll do, so now we will have to see for FSH levels. So we'll basically do the investigation. Why is the bleeding not happening? So that is why I'm taking the FSH levels. So to see whether the ovulation itself is happening or not. Okay, so FSH level I'll take. Okay, so if the FSH levels are high, okay, so if the FSH levels are high, there might be two types of cases. One is FSH high and still the bleeding is not happening. It might be premature ovarian failure. Okay, so prematurely ovarian failure has happened. Okay, so now no follicle is being matured. Okay, so maturation is not happening. So this is premature ovarian failure. Or else I'm gonna go for karyotypy. Okay, karyotyping I'm gonna do, and then decide what is the karyotype that particular person will be having. So what is the reason for gonadal dysgenesis that is happening? Okay, so there might be Turner syndrome, Swyer syndrome, and all these things, right? So that is why I'm gonna rule out the karyotypy, and that is how I'll diagnose. So this is when the FSH level was high. So suppose FSH level comes low. Okay, so FSH comes low, meaning, so from the pituitary itself the FSH is not being generated. That means there might be some issue with the pituitary, that is Kallmann syndrome or Sheehan syndrome. So what is Sheehan syndrome? So basically we learnt about PPH, right? So postpartum hemorrhage. After postpartum hemorrhage, what happens is, due to increased hemorrhage, so the pituitary blood supply will be compromised and pituitary will get atrophied. Okay, so this pituitary atrophy because of PPH is known as Sheehan syndrome. Okay, so please remember this. Okay, so these are the two things because of the FSH level. So now suppose the FSH is normal, but still the menstruation is not happening. So that is when we'll do progesterone challenge test. So basically we will give progesterone and see whether the bleeding will happen or not. So basically what we are trying to do is we'll be creating a withdrawal like action on progesterone. So we'll give progesterone after a certain period. So the progesterone level will be reduced. So that is how the bleeding should happen, right? Progesterone withdrawal. So let us see if the bleeding if there is no bleed, then we are going to go for estrogen plus progesterone. So basically we'll proliferate the endometrium, and then we'll try to give the progesterone, and we'll cause the so we basically are basically simulating a case of menstruation. The artificial menstruation is what we are trying to simulate here. Okay, so that is why we are going to give estrogen progesterone, and then we'll see whether the bleeding happens. So even then, if it is not happening, then it is going to be Asherman syndrome. Okay, so basically Asherman syndrome is adhesions in the uterine cavity. Okay, so Suppose if after giving progesterone, if the person bleeds, if the patient bleeds, it is going to be an ovulation that had caused this particular amenorrhea is the thing. Okay, so this is how you diagnose if the uterus is present. All these things you are supposed to do in the investigation. Okay, so this is what a gynecologist does basically when the amenorrhea is suspected. Now suppose I do USG and there is no uterus. Okay, absent uterus is there. So now what I'll do karyotopy. Why did the uterus didn't develop? Whether he is a male, probably there is a male karyotypy, or if it is a female karyotypy, but still it didn't develop, we'll see. Okay, suppose the karyotypy is XX, so if it is a female karyotypy only but still the uterus has not developed, it is most probably because of the Mullerian agenesis or MRKH syndrome. Okay, so this is why the uterus has not developed and there is no menstruation that is happening. Okay, Mullerian agenesis. Okay, so we discussed it, Mullerian abnormality. Okay, so what happens is here the ovary will be normal but the secondary sexual characters and all these things won't be generated. Okay, because of Mullerian anomaly. So Mullerian duct is what you are supposed to generate all the like uterus and all the internal organs, right? Here the uterus and all these internal organs are not getting developed, whereas ovary is normal. So that is why, so ovary normal meaning there is increased estrogen also, that is why breast will be present. Okay, breast and the testosterone, all this is normal, so that is why breast will be present in this particular karyotype. Okay, so this is how they'll give a case for you. Okay, so they'll give a case for you and you will have to find out all this manner. Okay, so in all this manner, so you will have to do a investigation by yourself. Okay, now suppose there is no uterus and doing a karyotype. Now I found out that karyotype is XY, but the parents have brought up the child as a female. So why did this happen? Why did they think that the that particular patient is a male, I mean female, but the karyotype is telling XY? So the thing is, there are two different syndromes. Okay, one is androgen insensitivity syndrome and another one is 5 alpha reductase deficiency. Okay, so androgen insensitivity syndrome meaning testosterone was what was supposed to develop all the secondary sexual characters, right? So here androgen is not able to put its action on the that particular receptors. So here the testosterone is high but there is insensitivity to testosterone that is happening. So that is why there will be secondary sexual characters absent, whereas breast will be present because all the testosterone will be getting converted into estrogen. Estrogen is what is important for the development of the breast, right? So that is why breast is present in AIS. Okay, here also in the karyotype XX Mullerian agenesis also breast is present because ovary is normal. Here also there is gonad and ovary is there. Okay, so that is what is producing testosterone and this testosterone is getting converted into estrogen and that is why breast is present. Okay, then coming to 5 alpha reductase deficiency, here there will be testis present. Okay, so here the testis will be present but there is no secondary sexual character. Okay, the reason being there is no conversion of testosterone to DHT. Okay, so DHT is very much required for secondary sexual characters to happen, but if the 5 alpha reductase is deficient, so there is no conversion of testosterone into DHT. So that is why there is no secondary sexual characters like for hair, the pubic hair and all axillary hair, nothing will be developed. Okay, so here the testis is present, please note that. Okay, so then if we see so if we see genitals, it would look like a clitoromegaly. Okay, so this is because see 5 alpha reductase is there, testosterone is there, but DHT was supposed to cause all these secondary sexual characters. Okay, and also the development of penis was supposed to be from the 5 alpha reductase and DHT support, but there is no proper amount of DHT that is that the genitals is getting. So that is why the clitoromegaly. Okay, so this is the management. Basically it will resolve by puberty because there will be increase in testosterone surge and all this DHT receptors will start becoming normalized. Okay, so that is the thing with the 5 alpha reductase. There is no need of management, it will resolve by puberty. Okay, Whereas in AIS, so basically the management will be we should remove the gonads. Okay, so this might turn into a germinoma cancer. So that is why, because here there is no differentiation of it into getting developed into ovary or testis. So that is why the gonad should be removed from the abdomen, or it might be also lodged in the inguinal canal. So that is why we'll have to remove the gonads. So that is the mainstay of treatment with AIS. Okay, so this is all and everything you need to know with respect to amenorrhea. Okay, so then now moving on to the major important topic, that is AUB, abnormal uterine bleeding. Okay, so palm coin, right? Remember, right, with from our final year, palm coin, that is P for polyp, adenomyosis, leiomyoma, malignancy, coagulopathy, ovulatory dysfunction, endometrial dysfunction, iatrogenic and non-classified functions. Okay, so this is how you the classify the abnormal uterine bleeding etiologies as. Okay, so now coming to abnormal uterine bleeding, so there are two types of bleeding that might happen. One is menorrhagia and dysmenorrhea. So let us see one by one. If there is more than 80 ml per cycle of bleeding that is happening, or if it is more than 7 days the bleeding is happening, so then we consider it as menorrhagia. The patient will come to you basically telling that there is too much blood that is being passed out. So how do you manage this patient is, so basically medical management, that is NSAIDs. Okay, so NSAIDs to reduce the painkiller, so it acts as a painkiller. Then tranexamic acid to reduce the bleeding that is happening, and definitive managements will be OCPs can be helpful, Marina and GnRH agonist. So basically all of this is what they are trying to do is, so basically normalize the pituitary hypothalamo pituitary and ovarian axis is what they are trying to manage. Okay, so OCPs, Marina and GnRH agonist is what we use. Suppose there is too much bleeding, we are going to go for blood transfusion based on the HB levels. Okay, so based on HB levels we are going to go for blood transfusion. Okay, if needed. Okay, then the surgical approach will be, if there is the bleeding is not getting controlled at all, we are going to go for endometrial ablation. Okay, then if not, we are going to go for uterine artery embolization. We'll try tamponade also. If not, if any of this is not working, we are going to go for hysterectomy. So this is with respect to menorrhagia. Now coming to dysmenorrhea, so this is basically painful bleeding, right? So primary will be there is no underlying pathology, it will be psychological, whereas secondary will be pathological. Okay, there is a underlying pathology which is causing the pain. Okay, painful menorrhagia, I mean painful painful menorrhagia. Okay, painful menses. Okay, the classification can be done as spasmodic, congestive and membranous type. Okay, so spasmodic will be contractive because of PG2 alpha that is happening. Then coming to congestion, basically pelvic venous congestion is happening, and with respect to membranous, there is something known as Schedas casts. Okay, so this is the thing with respect to dysmenorrhea. Now coming to uterine disorders. Okay, so so now that the in AUBs, so we'll be discussing about uterine disorders. Okay, so first thing will be non-neoplastic disorders. We'll discuss the first with the first one with non-neoplastic disorder, that is adenomyosis. So basically endometrial tissue in the myometrium is what is called as adenomyosis. So endometrial tissue was supposed to be in the endometrium of the uterus, but there is, so in the myometrium, if there is, so endometrial tissue was supposed to be in the endometrium. If the endometrium is in the myometrium, it is called as adenomyosis. Okay, why is this happening? Because of invagination of basal layer of the endometrium, or because of the metaplasia of the progenitor cells. Okay, so these are the two pathogenesis that can happen. Okay, then coming to clinical features, basically it is the abnormal uterine bleeding, dysmenorrhea will be there, and diffusely enlarged uterus or soft on examination will be there. Okay, so when we do the examination, this is the clinical feature the adenomyosis patient will present with. Okay, now coming to another non-neoplastic disease, that is endometriosis. Okay, endometriosis, basically endometrial tissue outside the uterus. So in the myometrium it was adenomyosis. If it is outside the uterus, that is the that is there, the endometrial tissue, it is called as endometriosis. Okay, so basically the pathogenesis is very similar to the and adenomyosis only, but here it is a retrograde menses that would have caused this endometrial tissue to go and lay in outside the tissue, outside the uterus, or probably because of metaplasia of progenitor cells. Okay. Clinical features, basically most common site outside the uterus where the endometrium can be found is ovary. Okay, so that is where the presentation of chocolate cyst might happen. When we take a laparoscopy and see why, during the investigation, it would look like a powder burn lesion. Okay, so powder burn lesion might be seen with respect to laparoscopy. Then the patient might present with chronic pelvic pain and abnormal uterine bleeding. Okay, so this is the presentation the patient might come in. Okay, so the investigation will be basically, I told you, right, laparoscopy. So gunpowder burn lesion will be there. So then MRI, it will look like a mushroom cap sign. Okay, so mushroom cap sign is what it will look like. Okay, so then coming to endometrial hyperplasia, a non-neoplastic disorder. So basically, normal will be less than 4 mm. Okay, endometrial thickness will be less than 4 mm, but if it is more than 4 mm, we are going to take it as endometrial hyperplasia. So basically, the pathogenesis is unopposed estrogen in this is most commonly in postmenopausal women. See, in menopausal women, this 4 mm is normal only, more than 4 mm, because the menstruation is happening regularly. But if this is happening in postmenopausal women, so it means that there is somehow estrogen is coming from somewhere. Okay, so this is because of unopposed estrogen that is happening. This might be because of hormone replacement therapy, PCOS, or obesity. Okay, so this all can cause unopposed estrogen to happen, and there will be increased endometrial hyperplasia. Okay, so this endometrial hyperplasia can be a high risk for endometrial carcinoma. Okay, so it might lead to endometrial carcinoma. So that is why we'll have to rule out the atypia. So that is why the management we do is basically we are gonna look for any pathology. So how we are going to do, any patient that comes with endometrial hyperplasia, we are going to do first thing is TVS. Okay, TVS is what we are going to do, ultrasound. Then after doing TVS, we are going to go for sampling. Okay, we'll take the sample for each and every patient, postmenopausal woman, for each and every patient that comes to you with endometrial hyperplasia. This is what we are going to do. Then we are going to take the biopsy. We'll do the biopsy and we'll send it for histopathological examination. There we'll decide whether it is normal or if there is a atypia. If the biopsy is normal, we are going to go for progestin, basically LNG, 11-orgestrol, and if it is a atypia, we are going to go for definitive management, that is hysterectomy. Okay, so basically progestin, we are going to give progesterone. Okay, so basically progesterone, and we'll try to, so basically we are trying to shed out all the endometrium that was present, endometrial layer that was present in the uterus. Okay, so progesterone withdrawal will happen after a certain while. So that is when all the shedding of the uterus will happen. So this is how we'll treat the endometrial hyperplasia. Then coming to endometritis. Okay, so please note, this is endometritis, not endometriosis. Okay, endometritis is basically, it happens post delivery. If there is a infection in the uterus, so inoculation of uterus by vaginal microbiota. Okay, so in the vagina, we know that, right, there is a normal microbiota, so which is there, but if it enters the uterus, that is during a delivery or something like that, or during any intervention, so that is when the infection happens. This leads to endometritis. The clinical features will be basically fever, uterine tenderness, and the purulent lochia will be there. So this is endometritis. Then coming to intrauterine adhesions, I told you, right, Asherman syndrome. Okay, so adhesions will be there. So fibrous band in the cavity will be there. The risk factor will be because of a D&C. Okay, so dilatation and curettage because of some other intervention would have done, and so there might be the adhesions that have happened because of this. The clinical features will be basically abnormal uterine bleeding, infertility will be there, recurrent pregnancy loss is there, or there will be dysmenorrhea. Okay, how do we manage it? So basically medical management is mitomycin C. Okay, so mitomycin C, we also discussed this in ENT, right? So this is the thing that we use with Asherman syndrome. Okay, So then coming to neoplastic disorder. So these are all the things that are non-neoplastic uterine disorders that we discussed about. So now we are going to go for neoplastic disorder, that is benign, that is leiomyoma. Okay, so leiomyoma is the is nothing but fibroid. So it is a non-neoplastic benign tumor. So there are types, okay, submucosal, intramural and subserosal. Because see, suppose this is the uterus. Submucosal, the fibroid might be here. Intramural, meaning it might be here, or it is in the subserosal area. So these are the three zones where the fibroid might occur. Okay. The clinical features will be, most of the time it will be asymptomatic. Okay, so the patient might present with abnormal uterine bleeding. Okay, intermenstrual bleeding and all will be there. So or so probably there will be a reproductive dysfunction, so infertility and all will be there, or there might be a pelvic pressure because of the mass that is present. Okay, so these, so most probably as asymptomatic. So these mass related issue is only what the patient will come to you with, okay, for the hospital. So here is where we'll have to differentiate between fibroid and ovarian tumor. Okay, so there is something called as groove sign, where we'll basically try to shake the by palpating, we'll try to shake the cervix and uterus. So here, if the groove sign is positive in fibroid, whereas groove sign is negative in ovarian tumor. So this particular leiomyoma is basically a estrogen dependent thing. Okay, so if the estrogen is increased, so this leiomyoma size will also increase. Okay, so how do we manage? Basically, it is expectant in less than 3 centimeters, so nothing, no intervention will be done. So basically will be symptomatic, will give symptomatic treatment, that is NSAIDs, tranexamic acid, then GnRH will be given. So basic the definitive management will be surgical management, which will be myomectomy that we do. Okay, myomectomy, myolysis or uterine artery embolization is what we do. Okay, or MRI focused therapy also can be done. So what are the complications that leiomyoma mostly lead with? See, because this is a benign thing, so there is no much of complication that it might cause. Because of some other thing, the complication might occur. That is, one is red degeneration. This is happening because of, in pregnancy, if there is a fibroid, this will lead to red degeneration. So red degeneration is a red beefy like color will be there with respect to fibroid and all these things. Okay, so might lead to intrauterine growth retardation, because there is a mass inside the uterus and which is hindering the normal growth of the embryo or the fetus. So that is why IUGR might be there, and also it might also lead to increased risk of breech presentation of the baby. So this is with respect to red degeneration. Whereas it can go torsion. So leiomyoma in subserosal, so subserosal is outside the uterus is there, so that is why it can go to torsion. So that is where we'll have to go and do an immediate surgery, that is surgical removal of this particular leiomyoma. Okay, so this is the thing with the non-neoplastic neoplastic uterine abnormality. Okay, so now the two main things, that is prolapse and PCOS, and we are done with all and everything with respect to gynecology. Okay, so prolapse is very very important. The main causes are because of weak pelvic floor, trauma to the supports. I told you, right, there are 3 levels of support we discussed, right? All the 3 levels with respect to D-lance is support. So if there is a trauma to those support, there might be prolapse. Or in asthmatics, and then atonicity due to reduced estrogen, there is increased pressure, abdominal pressure that is happening, so that would have led to prolapse. Then surgical approach, if there is a surgery that has happened to the gynecology, based on gynecology approach, then coming to birth injury, something is there, episiotomy, sutures that would have opened, and all these things would have caused prolapse. Okay, there is increased abdominal pressure also leads to, that is chronic RS infection. Okay, so all this leads to pressure building, and all the intrauterine organ will be prolapsed. Okay, so this is the causes of prolapse. Then coming to clinical features, there will be basically a mass per vaginum, coming out. Okay, there will be micturition issues, vaginal discharge might be there, then spine issues with respect to like back pain and all will be there. Then coming to the basically because of dragging pain that is happening, the spine issues will be there. And if it is the anterior vaginal wall that is involved, there will be cystocele or erythrocele. If it is the posterior vaginal wall prolapse that is happening, it will be the enterocele or the rectocele that will be happening. Okay, differential diagnosis with respect to this prolapse is Gartner cyst, cervical prolapse, chronic inversion will be there. Then coming to congenital elongated cervix or the rectal prolapse. Okay, so these are the differential diagnosis that we should rule out with respect to prolapse of uterus. Okay, then coming to classification, there are different types of classification: Shaw's classification, Baden-Walker classification, and POPQ classification. Okay, so the main that is important one is POPQ classification. Okay, coming to POPQ's classification, here we are doing the classification based on the hymen. Okay, so where does the organ lie with respect to the hymen? Okay, so stage 0 meaning there is no prolapse, stage 1 meaning it is more above 1 centimeter to the hymen, stage 2 is less than it is more than 1 centimeter below at or equal to 1 centimeter below or above the hymen. If it is more than 1 centimeter below the hymen, it is going to be stage 3, whereas stage 4 is complete vaginal eversion. Okay, so this is what the stage of POPQ classification is. Okay, then coming to complications that might happen because of prolapse is ulcerations, because of decubitus ulcerations, UTI, urinary tract incontinence, and pessary related issues. Okay, so we'll come back to management. Okay, so how do we manage this prolapse is basically based on how the patient presents with and with what age the patient is in. Okay, so if it is a mild prolapse, we are going to go for pelvic floor muscle training, that is Kegel's exercises and all. So Kegel's exercises is what we'll recommend for mild prolapse. If it is a non-surgical approach that we are going to do, it is basically pessary. Okay, so there is a pessary, so there are different types of pessary. If you want, go please see a different types of pessary. Okay, so this is a pessary ring that will be placing in the pelvis, so which will support the prolapsed parts. Okay, then the atrophic vagina will be treated with the topical estrogen. Okay, so this is the medical management of basically conservative management with respect to prolapse. So now if we are going to go for a definitive management, so this will be doing based on the age. Okay, so if it is a nulliparous young woman, we are going to go for abdomen sling. Okay, so abdomen sling is what we are going to do, and we are going to support the organ. Okay, the uterus organ. So suppose if it is young and parous women, we are going to go for Fothergill plus pelvic floor repair. Okay, so this is what we are going to do, or else we are going to go for Manchester procedure. Okay, so this is for young and parous women. If it is the older women, suppose 50 60 that age, so we are going to go for Ward-Mayo, you know that, right? Hysterectomy is what we are going to do, and then we are going to go for PFR, that is pelvic floor repair. So we are going to do PFR and Ward-Mayo procedure in older women 50 60 that year age. So suppose if the woman is very old and unfit for surgery, here is where we are going to go for pessary, or we are going to go for Le Fortis surgery. Okay, so this is the surgical approach that we are going to do for prolapse. Okay, so Fothergill, they have asked in the previous year. So Fothergill surgery is nothing but what we'll do is we'll place a mesh, and this mesh is fixed to the ischial tuberosity. Okay, ilium, ischium, and pubis, you know, right, in the pelvic muscle. So for the ischial tuberosity is will fix the mesh into. Okay, so this will support the pelvic organ. So then this is all with respect to prolapse. So now we'll move on to the important thing, that is PCOS. Now it has been named as PMOS, right? So 2025 guidelines gave it as PMOS, the new name. Okay. So what is happening is, so I'll tell you the entire pathogenesis, so it will be easier for you to know the clinical features and the management that we can do. So what is happening is, so because of genetic predisposition or obesity or lifestyle indifferences, it will lead to insulin resistance in a particular women. Okay, so this insulin resistance will cause hyperinsulinemia, right? So this hyperinsulinemia, what it does is it will stimulate the ovarian androgen synthesis. Okay, see, basically normally the ovary will be like generating the androgens and the estrogens and all these things. Okay, testosterone and estrogen, all this will be producing normally. But if there is hyperinsulin, insulin basically increases the testosterone level. Okay, so what happens is there is increased surge of testosterone. Okay, so there is increased free testosterone in the body. What it does is it will lead to GnRH pulsatile frequency. Okay, in the GnRH pulsatile frequency will happen. Okay, so GnRH basically will be pulsatile in nature. Okay, so it will be releasing in a pulsatile manner. But if there is an increase in the frequency, what it will does is it will increase the LH, but FSH will be reduced. So this is what happens if there is increase in frequency of GnRH pulsation. Okay, so normally there will be pulsatile release of GnRH only. When there is increased testosterone, it increases the pulsatility of that thing, and there will be abnormality in the LH and FSH production. Okay, so here the LH will be produced high, but FSH is low. So LH is producing, meaning all the theca cell will be producing androgen. Increase of androgen again is happening. Okay, so already the testosterone was increased. So here the theca cells also have started producing increased amount of testosterone. Whereas all this testosterone was supposed to be converted into estrogen, but here the follicle stimulating hormone is not getting released at all. So so how will the granulosa cell convert into estrogen, right? So all this testosterone is in the body itself. I'll come back to hirsutism. So this is how the thing is happening. Okay, so basically granulosa cell activity is reduced because there is no FSH at all. So all the testosterone is not converting into estrogen. So there is increased LH surge is happening. This increased LH surge is causing the ovulation to happen, but there is no follicle. There is no, see, increased LH surge was supposed to cause the ovulation, but there is no follicle to mature at all because FSH is not there, right? So this will lead to increased follicular arrest in the immature state only. Okay, so maturation was supposed to be happening by the FSH, but FSH is not there, so that is why immaturation of the follicles is happening. So this will lead to there is no progesterone release. Okay, if this follicle is not there, so meaning there is no ovulation, there is no corpus luteum. So corpus luteum was supposed to release progesterone, there is no progesterone at all. Okay, so and all the follicles that were arrested will lead to polycystic ovary. Okay, so this is how the name polycystic ovarian disorder came in. Okay, so there will be all the cysts. Now all the cysts will be in the immature state. So because there is no follicle FSH to get to convert this immature follicles into mature state, so that is why all the follicles will be in a polycystic manner. Okay, so now as there is no corpus luteum, there was no progesterone, so that is why there is irregular menstruation in this patient. See all these clinical features. Okay, increased testosterone had caused hirsutism, meaning all the facial hairs, like just like a man. Okay, mustache and all this beard and all might come in a women. And coming to irregular menstruation is because of this. I told you, right, there is a reduced progesterone, and when we see a USG, it is going to look like a polycystic thing, so that is why the name also. So this is all the thing that is happening with respect to polycystic ovarian disorder, now called as the PMOS. Okay, so, and also please note that hypothyroidism also might cause PCOS. How is this? I told you, right, in endocrinology. So if there is increased TSH, it might so in hypothyroidism, so there is increased TSH, right? So thyroid stimulating is hormone is high, but whereas T3 T4 will be low. That is hypothyroidism. So now TSH is increased. TSH also stimulates prolactin. So prolactin is antagonist to GnRH. So that is why GnRH is low. So here FSH and LH will be low. So that is why So there is no maturation of the follicles that is happening, so that might lead to PCOS like features. So that is why we'll have to rule out hypothyroidism in a case of PCOS. Okay, so this will just mimic like PCOS only. So that is why we'll have to rule out hypothyroidism with respect to all these PCOS cases. Okay, so now how is the patient is gonna present with? So basically obesity and all this hyperinsulinemia like features will be there. So that is what caused this PCOS, right? PMOS basically. That was the first etiology that was the behind this PMOS. So that is why obesity, acanthosis nigricans, basically all the depigmentation, pigmentation, hyperpigmentation that is happening around the neck, axilla and all these things. Acne will be there because high testosterone, hirsutism, androgenic alopecia might occur. Okay, so in this particular women. Okay, then there is irregular menses. I told you, right, there is no progesterone, that is why irregular menses, and infertility because there is no matured follicle at all. Okay, so these are the clinical features the patient might present in. So how do we do the diagnosis is based on the Rotterdam criteria. Okay, based on 2003 Rotterdam criteria. So any 2 out of the 3 things that I'm gonna tell, if it is there, we are gonna diagnose it as a PMOS. That is anovulation, hyperandrogenism, and polycystic ovaries on the polycystic ovary on ultrasound. At least more than or equal to 12 follicles should be there to diagnose it as PMOS. Okay, so anovulation, hyperandrogenism, or more than 12 follicles on the USG. So how are we gonna manage this? The first investigations that we're gonna do is hormonal investigations, metabolic investigations, and the imaging. Hormonal is basically LH and FSH ratio. It was supposed to be FSH more than LH, right? But here I told you, right, LH is high than FSH more than 2:1. So this is hormonal imbalance that is happening. Then the testosterone level, so total free testosterone will be high. Then coming to DHEAS will also be high. Then TSH and prolactin levels also should be ruled out. I told you, right, hypothyroidism can lead to PMOS. So that is why we'll have to rule out, is it the hypothyroidism that is causing this symptoms. Okay, then coming to metabolic investigations. So basically we are trying to rule out diabetes and all, hyperinsulinemia. So that is FBS level, HbA1c, OGTT, and all the lipid profiles we are going to do. Okay, then coming to imaging, it is going to look like a string of pearls. Okay, on imaging, so it will look like a pearly string of pearls will be there. All the immature follicles will be arranged like this. So this is the imaging. So how are we going to manage the patient is, so basically we'll tell them to lifestyle changes. So basically we are trying to deal with the causage first, lifestyle changes, then we are going to go for systemic approach. So to treat the irregular menses, we are going to go for progestin. We are going to increase the progestin and will cause the GnRH to get reduced, so negative feedback. Okay, so then coming to letrozole. So letrozole and clomiphene. So please remember these two drugs. Okay, letrozole and clomiphene. Okay, so letrozole, what it does is it reduces the aromatase and reduces the estrogen level in our body. Okay, so what it happens is, so when the estrogen is reduced, so that will cause a positive feedback for the GnRH to increase. So estrogen is reduced. This allows the GnRH to get released in a not in an increased frequency pulsatile manner, in a normal GnRH pulsatile manner. So that will lead to normalization of the FSH release, right? So that is how we are going to approach the letrozole way. Okay, so letrozole is a drug acting through normalizing the FSH. Okay, now coming to clomiphene. So this is the first line of drug that we are going to use in a patient of PCOS or PMOS. Okay, so what happens in clomiphene is, so basically directly it will reduce the estrogen in the hypothalamus, which will act on the GnRH. So again, positive feedback on GnRH, which will directly cause the FSH to release properly. So basically here also the same thing, but here we were acting on the aromatase, we are decreasing the aromatase and basically estrogen, but here clomiphene directly acts on reduction of estrogen. So this is the thing with clomiphene. Then coming to FSH, injections also can be given. So FSH is what is low, that cause the immature follicles to be there. So if we give FSH artificially, it can mature the follicles, right? So and also all the symptoms might be reduced. So this is the management approach medically. Okay, in symptomatic patients, the symptomatic approach for the treatment will be OCPs. Basically, it will increase the estrogen and reduce the testosterone by increasing the SHBG. Okay, so estrogen basically acts on the SHBG. Okay, SHBG is what regulates the testosterone level in our body. Okay, so estrogen increases the SHBG, which will reduce the testosterone, and all the hirsutism like features will be reduced in the patient. Okay, then in OCP, combined oral contraceptives, estrogen will be there and also progesterone, right? So progesterone will cause the reduction in endometrial hyperplasia, so that is how the menses will happen. So this is the basic approach that we do with respect to symptomatic treatment for PCOS. Okay. So if this doesn't work, then there is a surgical approach called ovarian drilling. Okay. So ovarian drilling can be done. So here on 2 to 3 follicles will identify and will drill on the ovaries. Okay, so this is the surgical approach for PMOS. Okay, so this is all and everything you need to know with respect to PMOS. So now let us move on to cancers. Okay, so please go to any of the textbook and please go to all the stages are important. Okay, all the stages of all the cancers, that is endometrial carcinoma, or coming to ovarian carcinoma, endometrial carcinoma, and the cervical carcinoma. Okay, so all these things, stages and their TNM stages and the management with particular stage is very important. Okay, so please go through any of the gynecological book and you'll be able to get it. Okay, so this is how we are gonna do. There is nothing for me to teach you. It is all about for you to revise, right? So that is why please go to any of the gynecological textbooks and you'll get to see this staging and management. That is more than enough. That is what has been asked all these years. Okay, so coming to CA cervix, so the reason why I want to teach you is because of the HPV vaccine. Okay, so HPV vaccination drive that is going on in India. Okay, so this was launched on February 28th of 2026 by the Home Ministry, so Government of India. So what they are doing is there is a quadrivalent vaccine that they are giving. The name is Gardasil 4. Okay, Gardasil 4. Okay, so there is Gardasil 9 in the market. Okay, so Gardasil 9 in the market, but the Government of India is giving Gardasil 4. Okay, so this is more than enough. Okay, so more than enough way of HPV action. So that is, it contains the variants for 16, 18 and the 6 and 11. Okay, 16, 18 is the cancer causing HPV, whereas 6 and 11 will cause the genital warts. You know that, right? Genital warts is the acuminator. Okay, so this will treat all these things. So that is why the vaccination drive is going on. So this is very important. Okay, so Gardasil 4 we are targeting 16, 18 and 6 and 11. Okay, so this is basically, this is the previous year question. Okay, it was asked in 2025. So basically we are focusing more on more than 14-year-old girls. Okay, so more than 14-year-old girls is what we are targeting on. So this is a single dose is given on IM anterolateral thigh. Okay, IM anterolateral thigh is what we are giving this particular drug into. So basically all the pentavalent hepatitis B and pneumococcal vaccine also given in the anterolateral thigh, right? So in the same way, this is also given anterolateral thigh. Okay, so the dosage is 0.5 ml. This is a single dose injection that we are gonna give. Okay, so then coming to another approach for carcinoma of cervix, that is pap smear that we do, right? So pap smear, I want you to know is prerequisites. Okay, this is a previous year question, that is why I want to teach you. So basically, ideally around ovulation is when we do the pap smear. No sex for 24 hours before the procedure. Lubricants won't be used, and there should be no pervaginal examination that has to be done before doing pap smear. You know that, right? Ayer spatula and ethylene glycol and all we use. Okay, so pap smear. So this is the thing with respect to CA cervix. Okay, and all the stages and all with all the cancers is very important. Please go see the TNM staging and the surgical approaches that we do for each staging. And then coming to one of the miscellaneous topics, that is with respect to cautery, that these questions have been being asked with respect in previous year topics, that is cautery that we use in hysteroscopy. Okay, so cautery methods, that is bipolar and monopolar. So bipolar we are going to use normal saline. Okay, so bipolar we are going to use normal saline, and also and in monopolar it is going to be glycine that we are going to use. Okay, so please be aware. Okay, so complication of hysteroscopic all these saline and glycine is basically there might be volume overload and pulmonary edema that might have happened. Okay, so pulmonary edema might be a complication with respect to the fluids that we are using. So that is why monitoring this amount of loss of fluid is very very important. This has been a previous year topic that they have been asking very recently. Okay, so for bipolar it's going to be normal saline that we are going to use, because there won't be any transmission that will be happening around the tissue with respect to bipolar, whereas monopolar approach we should use glycine, because we should avoid transmission that is happening. Okay, so then coming to posterior vesicovaginal fistula repair, sexual abstinence for 3 months should be done and avoid pregnancy for 1 year. Okay, so before doing the repair, so this is what we will tell the patient. Okay, sexual abstinence for 3 months and avoid pregnancy for 1 year at least. Okay, so before we do posterior vesicovaginal fistula repair. Okay, so this is all and everything with all the series. Okay, so now we have finished gynecology also. Everything with respect to all the topics are finished. So now it is up to you to revise all the topics, and now I'll give you the PDF, and all the important scores and all will be at the last of the PDF. So here all the important clinical scores, all the image based things that you are supposed to know, and all will be here, so that you can take a look at this at the last moment of your exam. Okay, so this is all and everything with respect to all the things. So the series is done here. Okay, thank you.